Good afternoon. So I'm Ross Lathan. I'm a vascular trainee in the East Yorkshire region. I'm currently on a fellowship with the Chief Sustainability Officer in the Greener NHS, based in the NIHR. And I'd like to extend thanks to IPC and ST for inviting me to talk today. So surgical site infections are a heterogeneous and disastrous problem at times. They range significantly from mild infections that can be managed easily with antibiotics to the complex, life-changing problems for patients. So there's a real big change. I hope from today I can highlight some of the benefits of prevention, but also the need that we need to be looking at those life-changing consequences of these problems. So very commonly accepted surgical site infection, problems that occur in the wound at an operative site within 30 days, or within up to 90 days for those that have had a prosthetic implant. There's a large number of risk factors that can contribute to patients developing these problems, in particular those with wound contamination, and there's guidance around the antibiotic prophylaxis for these nationally, but also operative and patient characteristics interplay within these. Now, the interrelatedness of these patient characteristics make this quite a challenging prospect for risk stratification, particularly for when we're looking at one-size-fits-all measures is not a good approach for prevention with these problems. Now, looking at the impact, so particularly for patients and outcomes, it's quite disastrous at times. There's on average, an inpatient stay is extended by up to about 10 days. Quality of life is impacted by a reduction of about 10% at 30 days. And there's a large range in quoted figures for the increase in mortality for patients that have infections. In terms of costs, there's also significant costs to the NHS. And this is, again, heterogeneous as you go across the different SSI severities. There's also the problem with antimicrobial resistance, particularly with additional and required antibiotics to be used, and multi-drug-resistant pathogens. Now, all of these impacts require a lot of resource use across different parts of the pathway, particularly from healthcare providers, but also from patients, and this attributes to a large environmental burden for the problem of surgical site infections. Then further with diagnosis, so the majority of these problems don't become clinically apparent until after patients have been discharged. And now often we don't see patients until around 4 to 6 weeks after surgery, meaning a lot of this problem is picked up from overburdened primary care services. So we've got a problem that is difficult to identify and predict, it's difficult to diagnose, and it causes a lot of problems. Now, to add an additional layer of complexity there, you've got the severity. Now, as we said, infections can range vastly from superficials, which may present as a painful erythematous wound, that could be easily managed with some antibiotics and the patient can remain at home, but right through to the organ space infections that require readmission, reintervention, potential ITU stays, and huge impact on patients' lives. I know if I were to choose which one I would want, I'd definitely be that superficial. And the incidence of these is obviously widely quoted, and as you're getting to smaller and smaller figures, it's harder to work this out, but roughly you see about 2/3 tend to be superficial, with the remainder apportioned across deep and organ space in different studies. But the evidence from here does become quite thin. Now, a meta-analysis did identify those with deep infections across 2 studies. Patients seem to identify a disease state worse than death as what they reported at 1 year after these kind of infections. And obviously, this evidence is weak, but you would expect as you're getting towards those organ space infections, that problem's even worse. In a study of almost 4,000 patients undergoing elective colorectal surgery, almost 80% of those with organ space infections had reintervention, and they also had 9 extra days inpatient stay compared to those with the superficial infections. So again, just clarifying the heterogeneous nature of these problems and the huge impact, particularly for those debilitating organ space infections. So where are we going from here? Obviously, many people will understand and seen the new NHS long-term plan, which highlights the shift towards prevention, digital health, and sorry. And this is where we need to be going towards with the management of infections, utilising digital health for diagnosis and looking at ways of preventing these problems. So in Yorkshire, we've been looking at collaborative ways of working and looking at a number of different work streams of studies to try and start seeing how we can move the needle on these problems. One of the things we did obviously mention and have come to realise is that big environmental and resource burden. But at this point, we didn't have any data to really clarify that. So before moving on to a prevention intervention, we wanted to understand what is that burden in our patients that are getting surgical site infection. And we looked at patients that are high risk for lower limb vascular surgery, so they have a lot of risk factors for developing these problems. So the boundaries for this study, we looked at patients from their surgery right up to when they were followed up, and then those that had infections until they were resolved. And these patients in our group were very characteristic of this high-risk population, a lot of them often being older gentlemen with multiple comorbidities, diabetics, smokers, and obviously the high-risk arterial vascular surgery, common femoral endarterectomies, lower limb bypasses. So real complex procedures with high risk of limb loss and mortality. So the infection rate in this group, this cohort study, was 22%, which again we see quite commonly in this group. And looking across that spread of severity, about half were superficial infections, just over a third being deep, and 14% at the organ space. Looking into the literature, this seems quite comparable. So in a cohort study over 1,000 patients, the exact same patient group, so having arterial groin surgery, their superficial infection rates were 54% and then 46% across the deep and organ space. So the group we looked at is quite representative of the population that we're studying. So moving on to those impacts that we found. So we measure in kilograms of carbon dioxide, which is quite a nebulous figure, but in terms of what that means, there's 643 kilograms of carbon dioxide per every infection. And that's roughly what it would take one tree 2 decades to remove from the atmosphere per infection. And when we look at the hotspot analysis, so where those problems, where that resource use is coming from, about over half is from the actual readmission themselves, so being in hospital and all the resources that are used alongside that. But then you've got other aspects like the additional procedures, the clinical reviews, and the medications that were being used. There was an additional 190 bed days on a standard ward and 5 high intensity, so that's level 2 or level 3 care days added. And again, that heterogeneity across that SSI severity is mirrored with that resource use and with the environmental burdens. Those superficial infections that patients can be managed at home having a relatively low impact on the environment, but patients that are needing to come back and having multiple procedures and multiple days of stay are a huge impact on the environment. And this exponential relationship was investigated and corroborated through an R-squared analysis as well. So basically, infections are bad for the environment, they're bad for patients, and as you go across that severity, we're getting worse and worse and worse. We wanted to then take that data into a real-world study looking at a prevention measure. So colleagues in Leeds then looked at a before and after cohort study looking at Leukomed Sorbact in the prevention of surgical site infection, and we analysed clinical, financial and environmental impacts in this. So this was a service evaluation, a prospective audit, and with a retrospective cohort comparison. I looked at all clean groin incisions undergoing femoral artery exposure at Leeds Vascular Institute, and we compared a simple island dressing to Leukomed Sorbact. Leukomed Sorbact is a bacteriostatic hydrophobic dressing, and the idea being with dressing changes, the bacteria are removed without bacteriolysis and should reduce infections. Standard operative techniques were used throughout for all patients on PrEP and for intraoperative and skin closure. And then cases were identified through electronic database system. There was an external team that looked at the data analysis and retrieval. And then it followed standard strobe guidelines, and data were conducted on SPSS. So the primary outcome was CDC using the standard definitions. We also looked at length of stay, readmission rates, reoperation for the groin infection, and the costs were also derived from the patient-level information costing system. And then we used our data from my first study to look at an environmental impact assessment from those outcomes. So looking at that primary outcome, there was a significant reduction by utilizing Leukomed Sorbact with a 68% reduction in surgical site infection. And those patients that had a simple island dressing, so the pre-cohort, had a 3.5 times higher risk of developing an infection compared to those who had the Leukomed. There appeared to be a trend towards reducing the severity of infection with the Leukomed as well, although with those small numbers, obviously that didn't reach statistical significance. The benefits were also realized across different surgical types, so endarterectomy, arterial bypass, and thromboembolectomy all showed benefit. So looking at the financial impact, so using the NICE base cost, which is around about £2,000 per infection, this study seemed to show a £30,000 in cost saving utilizing Leukomed Sorbact, and that's whilst considering the increased cost of those dressings in comparison to a simple island dressing. The surgical site infection was also associated with an increased median length of stay, that's 6 versus 44 days. And also using that patient-level data analysis, because the NICE base cost seems to be somewhat outdated, and looking at other studies also seems to mirror this PLIX estimate. It was actually around about £7,000 per infection, not 2,000. And that accounted to around about £700 saving per patient using this dressing. So then using this data with that environmental picture that we looked in the first study, we could then look at what is the burden to the environment and what's the difference by utilizing a potential new dressing. And that seemed to show a huge impact on the simple island dressing because of those additional severe infections and equating to around a 97% reduction in the environmental burden. So this was a collaborative, multiple industry approach to determine clinical, financial, environmental impact using Leukomed Sorbact in a real-world study. So it was obviously multiple hospital sites and the ST team who were able to support. We used patient-level data, did a cradle-to-grave pathway assessment to analyze that environmental impact. And we looked at hotspot analysis, which seemed to identify readmission, reintervention, and clinical review as key contributors to those burdens of resources and impact, and would be key areas to target in terms of interventions. There seems to be a severity gradient, which is particularly sensitive to clinical impact, resource use, and antimicrobial use. And I think it's really important to be looking at identifying this severity level of infections rather than a binary picture, as we're potentially missing out on a lot of good opportunities for reduction and benefits by doing so. So the dressing trial is a vascular surgical trial looking at Leukomed Sorbact versus simple island dressing, which is just under a data analysis phase. It's looking at high-risk vascular procedures, same sort of cohort, and we'll be looking at the benefits there, but I do think the severity will be a key factor in that. So there are limitations to these studies, so the temporal effects, obviously as we move on further away from the studies, the data is more and more inaccurate. Some of the emissions factors were required to be used on spend-based data, and as we get more sophisticated methods, there may be more accurate methods that we can use. And further corroboration would be needed to generalize these findings wider than this population and patient surgical groups. So again, a big thanks to the teams, obviously Tom Wallace in Leeds and the ST team in particular, who have supported this studies and work streams. And thank you very much for this opportunity.